Good morning, everyone, and thank you for joining us for this week's virtual journal club. My name is JP Brito. I'm an endocrinologist at Mayo Clinic and co-host of these virtual sessions. This morning, we are honored to have Dr. Jochen Lorch. Dr. Lorch is going to present today agnostic approaches to targeted therapy. Dr. Lorch is a medical oncologist and the director of both the Thyroid Cancer Center and the Endocrine Cancer Center at the Dana-Farber Cancer Institute. In addition, he's an associate professor of medicine at Harvard Medical School. He attended medical school at the University of Regensburg in Germany, and he completed 2 residencies, one in radiology at the University of Munich, and the other one in internal medicine at the University of Pennsylvania. Following his residency, he completed 2 fellowships in hematology and oncology, and one at the Martin Luther University in Halle in Germany, and the other one at Northwestern University. His clinical interests include head and neck oncology and thyroid cancer. And with that, I will turn it over to Dr. Lorch for your presentation. Thank you very much.
Yeah, good morning, and thank you very much for that nice introduction. It's really an honor to be able to present here. So I'll be talking about thyroid cancers and or agnostic approaches to target therapy, but focusing on thyroid cancer. Now let's see. Now I can't advance my slides. Oh, that's so. Hold on. How do I do this? Oh yeah, there we go.
Perfect.
Yeah. All right. Yep. Got it. Some conflict of interest. So when we're thinking of thyroid cancer, it's the most common endocrine malignancy with about 40,000 cases per year in the US, and the incidence is rising. It also seems that the more aggressive types of thyroid cancer are also becoming more frequent over the years. But there's also the majority of this 2.4-fold increase actually is by through the detection of usually a rather indolent thyroid cancers detected on health screenings and such. There's essentially 3 major categories of thyroid cancer by histology: papillary, follicular, and poorly differentiated, which are usually summarized as differentiated thyroid cancer, with papillary being by far the most frequent type, with an excellent 96% 5-year survival. This may have actually even increased with the advent of these newer therapies. Follicular thyroid cancer, a close second. Poorly differentiated thyroid cancer, much more aggressive, which is lesser overall survival. Then there are medullary thyroid cancers derived from the parafollicular C cells in the thyroid gland, also with a pretty good overall 5-year survival. And anaplastic, the most rare but also the most deadly version of thyroid cancer, with a 5-year survival rate anywhere between 0 and 14%, although it appears that this is also changing now. When we think of thyroid cancer, it is really a type of cancer that's characterized by a relatively bland genomic landscape, like here, for example, compared to others. Here's only listed BRAF mutations were relatively frequent, but there's nothing compared to the array of mutations seen, for example, in breast cancer, lung cancer, and many others. This is the Atlas data, about 400 cases of usually papillary, most of these cases papillary thyroid cancer, and most of these cases also indolent papillary thyroid cancer cases that underwent surgery and met the rather rigorous standards of DNA quality, and underwent sequencing. And what's striking, again, compared to other types of cancer, how bland the landscape is overall. About 60% have BRAF mutations, and a good portion of those are actually in this Atlas paper. A number of new, presumably activating BRAF mutations were detected. Then there's a group of cancers with NRAS, HRAS, and KRAS mutations, which do not overlap, so it's unusual to see both a BRAF and a RAS mutation together. And then the rest of this is just a smattering of a variety of mutations that may or may not be meaningful in this context. So generally a relatively bland genomic landscape. when we look at poorly differentiated thyroid cancer and anaplastic thyroid cancer, this becomes a lot more, the landscape becomes a lot more active. There we then see PI3 kinase mutations increasingly, particularly among the anaplastic thyroid cancers. SWI/SNF mutations, that's the SWI/SNF complex is involved in chromatin remodeling, an epigenetic process, also frequent, particularly in anaplastic thyroid cancer. And then also, again, a fair number of BRAF and RAS mutations, similar to what we see in differentiated thyroid cancer. But again, the more aggressive these thyroid cancers become, the more diverse is their genomic landscape. So just in general and with very broad strokes, the treatment, the early treatment of early stage thyroid cancer, so total thyroidectomy recommended for tumors greater than 4 centimeters. Lobectomy is acceptable for unifocal cancers up to 1 centimeter in diameter. It's not really clear what to do between with the cancers that are between 1 and 4 centimeters, whether to do lobectomy or and such. And this is an evolving topic, but we're not going to talk about this today. This is the general staging system, which, just like with any HACC staging system, is really designed to predict survival, not recurrence, but survival in any given cancer. And in thyroid cancer, it's following the usual pattern with the T stage based mostly on the size and whether it invades into adjacent structures, nodal stage depending on whether regional lymph nodes are there, and then of course the presence of metastatic disease. Where it gets a little more interesting and unusual is that there are actually two the stage systems for patients older and younger than 55, and again for those younger than 55 reflecting the generally good prognosis in this disease, which means that there's even with distant metastatic disease, patients are only classified as stage 2, as opposed to then the more traditional 4-stage system in the in patients older than 55. So now recurrence, which is not necessarily linked to survival in a rather slow-growing disease such as thyroid cancer, the risk factors there for people who will actually likely get into trouble later on is if there's gross extrathyroidal disease, the completeness of resection, histology, also plays a role. Are the hurtful cell cancers are more likely to recur and then become iodine refractory and such. And then also the mutational status, BRAF, are there TERT promoter mutations, PI3 kinase mutations, P53 mutations, and then also the thyroglobulin testing postoperatively, which has been around for a long time, and there's a lot of data on that. It's important to note that the recurrence risk, again, this does not necessarily reflect survival, but recurrence risk is a continuum, and it depends on many factors, and it ranges from a recurrence risk of about 1 to 2%, all the 1 to 30 to 55% if it's follicular thyroid cancer, for example, or with extensive vascular invasion, and then everything else in between. Differentiated thyroid cancer, when it recurs and becomes aggressive, it usually affects the lungs, bones, or both. Iodine, radioactive iodine does have a role in metastatic disease, and there are complete remissions possible between 30 and 43%, although it's quite limited, especially with respect to size. I think lesions that are generally larger than 1 centimeter are unlikely to be eradicated by radioactive iodine, but it's always worth a shot because it's a relatively easy treatment. But in many of these cases, eventually iodine refractoriness develops, which is defined as at least one lesion with no uptake progression within a year following a radioactive iodine dose, or persistent disease with a total cumulative dose of 600 millicuries, which this day and age is relatively rare to achieve. So for patients with iodine refractory disease who require systemic therapy, the first line of treatment and the first type of drug that was developed were the tyrosine kinase inhibitors. The first of them was sorafenib, and initially after following some initial phase 2 studies, then tested in a phase 3 study. That was a double-blind randomized multi-center phase 3 studies in patients with iodine refractory incurable disease. They had to have progression within 14 months to screen out patients who have metastatic disease or have a few lung nodules, but disease stability and really do not need treatment. There was randomized 1-to-1 to sorafenib versus placebo, and the progression-free survival was the primary endpoint. There were 417 patients randomized, and there was a significant difference between the treatment arm and the placebo arm, which led then to FDA approval. The perhaps most interesting data is actually in the supplement of this paper, and it shows the BRAF versus BRAF mutated versus BRAF wild type populations. And as you would expect with the tyrosine kinase inhibitors, the BRAF mutant cases actually generally fared better compared to those with BRAF wild type. But what was surprising was also that the BRAF mutant cases actually in the placebo arm also took a longer time to progress compared to those with the wild type, which is somewhat counterintuitive, right? So because BRAF V600E mutation is generally associated with iodine refractoriness and aggressive growth. So why would people then, once their disease becomes iodine refractory, why would people then have a worse prognosis? The obvious answer is, in this population that's iodine refractory, there must be worse mutations going on compared to BRAF mutations. The question is, which ones are those? We have a few answers to that, but not complete. This is not completely understood. Lenvatinib then also followed suit, and in a very similar trial with similar size, although randomized 2-to-1 to the treatment arm, also placebo-controlled, progression also within 13 months to select for cases with aggressive disease, and then a crossover was allowed, and progression-free survival, just like with the decision study, was progression-free survival, and there even greater difference between treatment arm and control arm, with a progression-free survival of 18.3 months versus 3.6 months, including 4 CRs. So this was also highly positive. The drug obviously got FDA approval, and if you look at the subgroup analysis, essentially all subgroups benefited similarly, and including those who had prior tyrosine kinase inhibitors, which is here. So there's essentially no difference between those two groups. Also, RAS and BRAF status also did not really affect the extent of their response very much. So I think most people would consider lenvatinib as the standard of care for first line. Sorafenib is acceptable, and other tyrosine kinase inhibitors are probably also VEGF inhibiting tyrosine kinase inhibitors are probably also similarly effective. For second line, there was recently presented at ASCO data with cabozantinib, which also was statistically significant. So as second line, one could consider carboplatin, especially once it's FDA approved and will be covered by insurance. Now, how about more specific inhibitors targeting BRAF, for example, since it occurs in about 60% of all differentiated thyroid cancer cases? There's a phase 2 study with 51 patients with iodine refractory disease, split up into 2 cohorts, one with tyrosine kinase naive patients, the other with previously treated with TKI patients. And the PR rates were partial, so radiographic partial responses, 35 and 26%, depending on prior treatment with a TKI. But the clinical benefit rate was actually quite favorable. Perhaps overall somewhat disappointing compared to some of the other VEGF tyrosine kinase inhibitors, but still a side effect profile generally quite favorable. And as you can see here in these waterfall plots, most patients get some kind of benefit, at least disease stability for some time. So even though this is not FDA approved, it is definitely a possibility for patients who have BRAF mutations. The other nice thing about detecting BRAF mutations is that this can be done based on immunohistochemistry alone, so you don't necessarily have to have next generation sequencing. This is a relatively easy stain that can be done at the pathology department, and provides another avenue for treatment. The other BRAF specific tyrosine kinase inhibitors, the dabrafenib with or without trametinib, have also been tested in this disease and also show some decent response rates. In anaplastic thyroid cancer, surprisingly, there were some data. This was part of a larger basket trial in BRAF mutant cancers, not just thyroid cancer. And there was this group of 16 patients with anaplastic thyroid cancer that was a BRAF mutant. And remarkably, there was a response rate of 69%, and the duration of response also were quite impressive. The side effects often not so easy. Like pyrexia is definitely is a problem. I've seen this go all the way to an almost sepsis-like syndrome. Nausea also fairly frequent, but again, with such a deadly disease, these response rates are very impressive. Again, on waterfall plot, most patients actually having some kind of response. I have to say, when in my practice, I see a lot of mixed responses, and not so much these profound, long-lasting responses. Although I definitely agree that those do exist. Anyway, the drug is FDA approved based on these 16 patients, and it can be used for treatment in these patients. In fact, it's also NCCN guidelines recommended. It can also be used neoadjuvantly, which is, there's some data retrospective at this point, but the trials to examine this in a prospective fashion are underway to make anaplastic thyroid cancers more resectable. And we'll have to see where these trials lead us, but definitely a sort of a glimmer of hope for patients with anaplastic thyroid cancer, at least for those with BRAF mutations. Activating RET abnormalities are also quite frequent in thyroid cancer, and essentially through two mechanisms: mutations, which occur predominantly in medullary thyroid cancers, where you have mutations that lead to dimerization of the RET proto-oncogene and thus activation. Then you also have mutations that actually constitutively activate the intracellular portion of the RET molecule. And this, as I said, plays a role in medullary thyroid cancer, whereas RET fusions are more frequent in papillary and differentiated thyroid cancer, papillary in particular, also with fusions with dimerization with a fusion partner that leads to dimerization of the tyrosine kinase portion of the molecule, and thus activation. So in papillary thyroid cancer, this seems to be the case in about 5%, and anaplastic thyroid cancers about 1%. So this was so in medullary thyroid cancer, we all know sporadic forms are much more frequent than the familial forms, although genetic testing is a requirement. They come in the germline mutations come in association with a number of syndromes, MEN2A and B in particular, but there are also a few others. This is just a general outline of these syndromes. Now, multi-tyrosine kinase inhibitors that predominantly target VEGF, such as vendetinib and cabozantinib, have been tested. And now there's also some data with lenvatinib, but these were the two large phase 3 studies that are out there. First, the one with vendetinib, which was done early on. It's 331 patients with advanced medullary thyroid cancer, measurable disease, but no progression required, which is important. Only a calcitonin level of greater than 500 was a requirement. Vendetinib was used at a rather ambitious dose of 300 milligrams or placebo. Crossover was allowed, and progression-free survival again was the primary endpoint. And there was a significant difference between these two groups in PFS. However, so the PFS for the vendetinib arm was actually not reached and was 19.3 months for placebo. Now, these are people who essentially had no treatment for a year and had no progression for a year and a half. So you could argue these were probably not people who should have been on any treatment trial and should just have been monitored. But again, this was a reflection of this entry criteria as without requiring progression at enrollment. Cabozantinib then tested in perhaps a more real life setting with also again 330 patients, but with disease progression within 14 months, no limit to prior therapies, and PFS was again the primary endpoint. And here now clearly a large difference in progression-free survival, 11.2 versus 4 months. And again, both drugs have received FDA approval based on this and are now still widely in use. Now, again, subgroup analysis showing essentially a similar benefit for all these patients with cabozantinib and patients with one of the more notorious RET mutations, which is mostly in sporadic, non-familial medullary thyroid cancers, actually might have had a little bit of a has a greater benefit than the rest. There was some suggestion of perhaps a survival benefit that did not pan out in the final analysis, but this more aggressive RET mutation seemed to respond really well. Somewhat reminiscent perhaps on the better response in BRAF mutant differentiated thyroid cancer. But the side effect of these drugs are rather severe. So most patients requiring dose reductions, lots of fatigue, and all these, we're all familiar with that. So the question is, could this be improved by a more targeted agent? And I'm sure you've heard of these of the RET inhibitors, selpercatinib and pralsetinib in particular, that have tackled RET mutant cancers and thyroid cancer in particular. Relatively early on. Both are potent and selective inhibitors of RET alterations, both mutations and fusions, and largely sparing VEGF receptor 3, so less hypertension, bleeding and clotting problems. So they were tested, among others, in medullary thyroid cancer and RET fusion positive papillary thyroid cancer. These were cases that were intolerant or had progressive disease and standard of care therapy. And the primary objective was overall response rate and safety. These were extended phase 1, two of these extended phase 1 studies with multiple patients enrolled in multiple tumor types. Selpercatinib recently published in a New England Journal, and this included 19 patients with RET fusion positive thyroid cancer with a response rate of 79%, progression-free survival 64%. There were also 2 patients with ATC, and 1 had a response. Similar data with pralsetinib. These were predominantly medullary thyroid cancers and a few fusion positive papillary thyroid cancers, and there are also a response rate of about 60% and a fairly high overall disease stability rate, almost of nearly 100%. Now the question is, which drug should you use? BLU-667, LOXA-292, or selpercatinib, pralsetinib, and the question is, of course, that this is a question that will never be fully answered. Comparing the trials, which is not entirely legitimate, but the response rates seem to be quite similar. The question, of course, can you use them sequentially? And that seems to be usually not the case. Most of the resistance mutations are gatekeeper mutations or Sullivan front mutations there, where there's cross resistance between these two drugs. I personally use them in an alternating way, but I think there's, in terms of efficacy and side effects, there's really not much of a difference. Compared to the tyrosine kinase, the broader tyrosine kinase inhibitors, the side effect profile is very is actually very mild, and you don't need these data. If you walk into a room with a patient with any one of these RET specific inhibitors, as opposed to the VEGF inhibitors, you know that right away. They're much less fatigued. There's obviously much less issues with hypertension, although it still occurs, and there are and they're just generally more themselves. They gain weight and so on. Now on to the ALK mutated thyroid cancers. Now that is quite rare. It may occur, it's according to some data, in 11% of anaplastic thyroid cancers, although there's other data that suggests it's more like between 1 and 5%, and I believe that's probably also that's probably accurate. But if these mutations do occur, there seems to be a high response rate to crizotinib. It has never been explored in a more systematic way, but there are a few cases out there in the literature. What's also interesting is that resistance to one drug, for example, ceritinib, after 36 months in this particular case, was then still responding to following crizotinib. Sorry, a patient was placed in ceritinib and again had a response. So it's definitely something worth looking for. Now, this is obviously something that, just like the RET mutations, that require next generation sequencing, but as it's becoming increasingly available, this is becoming less and less of an issue. Now, finally, the NTRK fusions, which are come in 3 flavors: NTRK 1, 2, and 3. In thyroid cancer, NTRK 1 and 3 are by far the most frequent, especially NTRK 3. Similar to RET fusions, the activation typically happens through a fusion partner that leads to dimerization and thus activation of the molecule. There are a few cases also with point mutations, but the classical way of NTRK activation is through a dimerizing fusion partner. There's a number of fusion partners that are relatively specific to NTRK 1, 2, or 3. And then lead to activation. Now, again, phase 1 basket trials for patients with tumors that carry any one of these fusions was evaluated. These were 55 patients treated with larotrectinib in a phase 1 study. There were also a number of thyroid cancer cases and one anaplastic thyroid cancer case treated in this cohort. Almost everybody had at least some response rate of formally of 75%. Very few primary failures, and again, many people still on trial and on active treatment per this swimmer's plot. Side effect profile generally very mild, rare neurologic problems. Again, no comparison to the multi-TKIs. Patients are generally very happy with this drug. A similar drug as entrectinib, also tested in a very similar phase 1 study, again with a number of 5, in this case 5 thyroid cancer cases that were NTRK, usually NTRK 3 fusion positive, and the response rate somewhat perhaps lower. But again, these are such small trials and such diverse patient populations. One included pediatric tumors, other didn't. So I think that that's just my personal opinion, but my feeling is that these are very similar drugs. If I have a patient with one of these abnormalities, I usually alternate between the 2 drugs, and have so far not seen any major discrepancies between the two. Now, mTOR has been around for, or mTOR inhibitors have been around for a long time, such as things like everolimus, rapamycin analogs. There are also very specific inhibitors of the FK526 or rapamycin binding pocket and inhibit mTOR complex 1. We tested everolimus in a phase 2 study. There are 2 other studies, one from Hong Kong and the other, or Taiwan, and another one from Europe. All finding more or less the same efficacy of everolimus in a group of patients with very aggressive disease and progression within 6 months. We saw a PFS of 12 months and disease stability of or more for about a third of the patients. It also works pretty well in Hürthle cell cancer. And I have to say, I still have to see a patient who does not have at least disease stability for some time on everolimus. What's interesting is there's a trial that was also just recently presented at ASCO, which combined everolimus plus sorafenib with a very similar progression-free survival compared to everolimus alone. So the question is, should these 2 drugs be rather perhaps treated or used sequentially versus in combination? Well, we don't know, but everolimus is also NCCN recommended for iodine refractory thyroid cancer, and does have some activity. What's perhaps not so compelling about it is that there's really no association with PI3 kinase or activation of the PI3 kinase mTOR axis. The strongest predictor for response was actually BRAF V600E mutation, and that is again very similar to what was found with lenvatinib and sorafenib. So it's not, even though it's very specific and the target that it hits, it's not as quite so specific in terms of, or it doesn't allow predictive markers. Now, how about immunotherapy in thyroid cancer? Well, as you recall, the genomic landscape is very bland, so there's not a high mutational burden, and there's probably not very much for the immune system to latch onto. This was initially also then shown clinically in the Keynote 028 study, which again was one of the early pembrolizumab studies that also included 22 patients with iodine refractory thyroid cancer, where pembrolizumab had a PR rate of 2 out of 22, so 9%, somewhat discouraging. Where it seems to work rather well is anaplastic thyroid cancer. So there was a phase 2 study with spartalizumab, which is Novartis's version of a PD-1 of a PD-1 inhibitor. It was tested in 40 plus patients, 42 patients with anaplastic thyroid cancer, and there was a 19% radiographic response rate. And we and others have some data that CTLA-4 inhibition may be also effective in this disease. This is the spartalizumab data that was recently published. Again, it was a phase 2 study, 42 patients enrolled, and the response rate, as I mentioned, was 19%, but then with also a number of patients who had disease stability. These are some of the preclinical studies that we had. There's at MIT and at the Farber, there's a group that's interested in exploring in vitro immunotherapy testing system, which consists of a small collagen cylinder in which tumor cells are grown into spheroids, and we that can then be analyzed all types in various ways. And when we looked at this in thyroid cancer, we saw that these are some of these spheroids. We saw that CTLA-4 was particularly effective in blocking tumor growth, inducing tumor cell death. So actually, there's actually a little video if I can show this. So you see, this is one of these spheroids, and you see these lymphocytes dancing around it, and then eventually, especially if you focus on this area down here, this is getting lighter and thinner. as they're chewing away on this tumor spheroid. This is over the course of 2 hours, so it didn't eliminate it completely, but that's what we saw when we treated with a CTLA-4 inhibitor. That was the basis for a trial that was combining ipilimumab and nivolumab with a non-small cell lung cancer dosing regimen. And these were the results of the entire cohort. This was presented last year at ASCO. The blue bars here represent anaplastic thyroid cancer, and if you magnify those out, there was out of 10 patients that were with anaplastic that were enrolled, there were 8 who had analyzable data, did not progress too quickly. And among those 8, there were 3 with profound responses, and 2 of them are still alive and without evidence of disease at the moment. So that's obviously very encouraging. This is one of those cases, metastatic anaplastic thyroid cancer, which then over the course of 2 years roughly goes away. And again, 1 year after her last infusion is actually still without evidence of disease. So to conclude, I think it's pretty clear that targeted therapies have led to improvement of the prognosis in iodine refractory differentiated thyroid cancer, medullary thyroid cancer, and also finally in anaplastic thyroid cancer. There are the more targeted specific therapies that show good efficacy and improved tolerability compared with older multi-tyrosine kinase inhibitors. And genetic testing is for most cases necessary to match patients with their optimal treatment. And with that, I thank you for your attention, and let's take some questions.
Dr. Lorch, thank you very much for such astounding presentation. We do have some questions from the audience. Dr. Pitoya asked the number of included patients in the differentiated thyroid cancer in both palcitinib and sepercatinib trials is probably indicating the very low frequency of these alterations. Do you think that it might be even lower than 5% in real patients, real life for radioactive iodine refractory differentiated clinical thyroid cancers?
Yeah, I think that's a good question. I mean, I think the verdict is still out. You know, it's also, I think it is more on the rare side. However, to find it reliably, you have to make sure that the assay that you're using or the company that you're using is actually testing for it. And until recently, that wasn't universally the case. Fusions, whether it's NTRK or RET or anything else, are generally fairly difficult to detect on these next generation sequencing panels unless they have an appropriate bait set that amplifies the section of the gene that represents this fusion. And as I said, that wasn't universally the case. So I think in the past we may have missed a lot of those cases. But I agree. I think in real life, is it going to be 5 or 10% or 15, as some people have claimed? My feeling is it will probably be on the lower side. It probably also depends on which case you pick clinically. So if you pick the more aggressive iodine refractory thyroid cancers, you may, in that patient population, people who progress within 12 months or even 6 months, you may have you may have a higher incidence of this fusion.
Thank you, Dr. Lorch. And one question: how enthusiastic have you become over the last years in regards to the effect of these targeted therapies with trying to overcome radioactive iodine? Trying to bring some restoration to radioactive iodine response. Initially, there was a lot of enthusiasm about it, and it has been thinning out in regards to whether or not that's actually something that we are seeing as a significant effect.
Yeah, so that is also a good question. And I actually had this in the presentation, but took it out because it is not really clear where this is going. So yeah, as you mentioned, in the early 2010s, there was this New England Journal paper out of Memorial Sloan Kettering in a number of patients where there was a high rate of redifferentiation with a MEK inhibitor, particularly in cases that were RAS mutant. And the hope was, of course, maybe by increasing iodine avidity, maybe we can then cure additional patients who otherwise might go on to, or might not be, would end up on palliative treatment. And I think sort of, over the years, it's become clear that enthusiasm or that won't pan out. There are also still a number of trials going on in BRAF mutant, and then also with things like BRAF plus MEK or without MEK, with or without a MEK inhibitor, also trying to redifferentiate. And it's clear that, yes, it does recruit this sodium iodine supporter to the cell surface. And there is a higher rate of iodine avidity, and there's actually also a relatively high rate of decrease in thyroglobulin and perhaps progression-free survival. But eventually, these tumors seem to recur. I think where this may have a role in the longer term is it's just one additional tool in the toolbox, so to speak. It's relatively easy treatment, radioactive iodine. At doses below 150 are generally pretty well tolerated. The MEK inhibitor or BRAF plus MEK inhibitor is given over the course of 4 or a number of weeks and not on an ongoing basis. So it's a one-time treatment. And in that sense, I think it's attractive. However, is it going to cure cases? Not clear. There's one trial that's looking into answering that question. High risk thyroid cancers that undergo redifferentiation therapy following surgery. But it's a relatively, I don't think that this trial will give us a lot of answers because it's a relatively small trial and the follow-up is relatively short. And as we all know, these cases, if they do recur, they often recur after a long time, not after 1 year, but perhaps after 3 or 5 years. So I think this is not going to be providing us with a whole lot of information. So I think it may be something to consider, but at this point it's not FDA approved. The drugs are out there, so you can get them, you can do it, but it's not clear if that's really worth the potential side effect of another round of radioactive iodine.
No, yeah, I do agree. Do you have any personal experience or there has been any reports of the new RET inhibitors in regards to redifferentiation with radioactive iodine? I haven't seen anything yet. No?
No, I haven't either. I think that, obviously that would be limited to the RET fusion positive cases. And then, and those are rare, but yeah, that would probably, I'm sure we'll see some case reports either maybe out of Mayo or or one of these places, but to do a study will be very difficult because then you'll also be competing with those RET inhibitors, and it won't be an easy trial to conduct.
Yeah, no, for sure. And do you, when you regularly treat these patients, for instance, with VEGF inhibitors, do you check once in a while just in case maybe an uptake radioactive iodine scan to see that something has changed, or you never incorporate the radioactive iodine scan at one point during the follow-up treatment?
Yeah, no, I usually don't, and I think the endocrinologists that I'm working with are generally also not so enthusiastic about it. I think the question would be then, what if you do find some increased uptake, do you then stop, or do you then treat with iodine and then stop, or it's an interesting question. But I think no. So, but the short answer is no. I don't do it.
No, my experience has been that it has been in few cases some of those do have an increased uptake, but I'm not quite sure to say that the patients really benefit from even the use of radioactive iodine in those instances when the uptake is new. But yes,
Yeah.
and Dr. Pitroya has another question as well here, and it says, do you have any experience with the use of selitrectinib or repotrectinib in those patients who become etrectinib or lerotrectinib on target resistant?
Yeah. No, not personally. I do not.
Mhm. Um, Something that I think is quite relevant now is that the use of these targeted therapies brings the importance of multidisciplinary teams that in the past probably they were not that needed, or were not clearly there for groups. How does it work in your practice in regards to the partnership with the endocrinologist and the surgeon? How
Yeah.
do you come up with this multidisciplinary work team?
Yeah, I think I think that's becoming increasingly important. Um, so as patients are becoming, the cases are increasingly complex. I mean, if you recall, years ago, thyroid cancer patients usually would not even see a medical oncologist,
Mhm,
uh, and they would, because there was essentially nothing we could offer them. There was, sorafenib and lenvatinib and many of the other tyrosine kinase inhibitors that are quite similar. So I think so it's increasingly important. I think also as treatment goes on, it becomes more important to also then have the input from surgeons and endocrinologists for things like redifferentiation therapy. Is that something that makes sense to pursue at a given point? But also, for example, in anaplastic thyroid cancer, I think it's crucial because you do have a high rate of mixed responses to these BRAF inhibitors, for example. And what I and also the group at MD Anderson has done quite a bit is then have surgeons, take out selectively disease that is not responding, and then just
mhm,
continue on a BRAF and MEK inhibitor, for example. Um, or similarly, also in with immunotherapy, and I have a number of cases where we did just that. So where patient had a response, say some lung lesions responded to nivolumab and ipilimumab, but a neck lesion started to creep up, and if it was reasonably accessible, we've removed those in a number of cases, and frequently then got a surprising amount of time out of this without further progression. I think radiation with techniques such as quad shots, these a 2-day course of radiation delivered in 4 fractions. I think it's also something that's very feasible, that has a lot of benefit in some cases, because it just stops growth at least for 6 months or so, fairly reliably. It can be repeated. It's also it has much fewer side effects than the traditional chemoradiation course of 6 weeks with doxorubicin or carbotaxol or anything like that. So I think as these cases, and especially the more aggressive cases, evolve, it's more and more important to then have the input from surgeons and radiation oncologists and endocrinologists, also pathologists, and so what we've gone from one thyroid cancer conference once a month, which was essentially a surgical conference, to a weekly multidisciplinary conference with all disciplines present, and increasingly discussing these these complex cases, also discussing them repeatedly, or not repeated, but as time goes on, and as the patients then as their stories evolve, and as we have more and more treatments that are available, I think it's increasingly necessary to manage these patients with multiple specialties involved.
No, absolutely. And particularly now, because many centers across the United States are actually thinking about creating multidisciplinary teams to address advanced thyroid cancers. I think it's something that you keep hearing and many colleagues saying, how we gonna set this up, and you have successfully created your thyroid cancer center and leading this kind of thyroid cancer center as well. What is the best advice for junior or middle level career individuals who are thinking about setting something up in their institutions in regards
Yeah.
to cancer centers?
Yeah, so I think it's a real for young oncologists who are looking for their niche. I think it's a good career path. Again, 10 years ago it didn't exist, but it is there now. There's an increasing number of these targeted therapies and an increasing number of treatment options. I think it is definitely something that any head and neck oncologist I think should consider. Now, the thyroid cancer, and especially those advanced thyroid cancers is the incidence is increasing. Patients live longer, and the cases are becoming more complex. So I think for most institutions, that was the same for at Dana-Farber. The patients were already there. All the the endocrinologists, the surgeons, radiation oncologists, pathologists, they were all there and somewhat interested in thyroid cancer. And what it took was then to essentially formally come up with this entity called the Thyroid Center at Dana-Farber, which then really became sort of galvanized all these different elements together very quickly. So it was easy because the time was ripe, and the people generally are there. I mean, there's a lot of people who treat thyroid cancer, and from the institutional standpoint, it should also be attractive. I mean, our thyroid cancer patient numbers have gone through the roof after we had this established and put it out, and it was out on the internet. So I think that's very that's very viable. I think the main step is really to take the initiative and do it, and then also have have somebody put together, keep track of patient lists for these weekly conferences, and make sure that everybody's there, and all these things that are come with everyday life. But in general, I think it's probably easier than you would think, just because
Yeah,
there's a need.
absolutely. And I think the you mentioned a few times the importance of multidisciplinary tumor boards, and I completely agree that it seems to be that sparks the collaboration of a multidisciplinary team, and when you are centering the collaboration of what is best for patients. So I agree as well that has been our experience at Mayo, a process that started with tumor boards led by Dr. Ryder here, and that actually I think has brought a lot of benefits to the multidisciplinary team. Absolutely. Let me ask you maybe the last question or before the last one. One concern, again, after the few years of using these medicines, is some level of these disparities in regards to who is able to afford them and who is able to access them. And yet, at the beginning, of course, everything was new. But after a decade or more using now these therapies, what are your thoughts about disparities in the way that we use these interventions?
Yeah, it's a big problem. I was giving a very similar presentation in Venezuela remotely, and that was also their, of course, their concern. It was like, well, it's great that these drugs exist, but how can we get them? And I mean, the same disparity exists even within the same, within the U.S., where these depending on insurance, these people may or may not be able to get them. I mean, even uh, if an insurance plan covers 80% of the cost, well, if a drug costs 15,000 a month or more, which is essentially what these drugs are, then 20% may also put some of these out of reach. So there are then these programs through the drug companies where people can apply for support and get the drugs and so on. But I find this process in most cases relatively cumbersome. It usually helps if you have two very similar drugs, such as selpercatinib and prazosinib, or entrectinib and larotrectinib. So then the companies seem to, or these programs seem to be a little bit more responsive than in other cases where there's just one. But yeah, that is a big problem, and it's also, I mean, there's a whole back office, at the Pharma, and I'm sure that's same at most places, of people who do nothing but getting these drugs approved, which is just also very, very costly, which adds adds to the problem. So I think this is these I mean it's understandable that companies want to recoup their development cost. I mean, to develop and try to market a drug that's
Mhm.
that targets a gene that's perhaps like in 1% of cancer of a few cancer cases, such as NTRK, then these things have to be expensive, I guess. But does it limit the utility of this whole approach? Yeah, absolutely.
Yeah,
Uh,
I agree.
yeah. So is that your experience at Mayo also?
Well, I think the fact that we ended up treating the ones that come back, the ones that are here, is because certainly there is a group of people that cannot really go through the same pathway and never get the chance to be here to begin with. And I think these disparities will be more pronounced as we go by with the use of these therapies and we start understanding more about it. There is one last question, Dr. Lorch, sorry. Say, can you speak more about managing the toxicities of therapies and consideration for patients who failed therapy? What do you envision for future treatment options and strategies?
Yeah. So in general, the management of side effects is much easier for the more targeted therapies than for the more broader tyrosine kinase inhibitors. So I mean, you have to look at the profile and be aware. Also be aware of, since many of these drugs are still relatively new, be aware that there are some drugs. I mean, I find, for example, that the uh, the RET inhibitors do seem to also affect things like mood to some degree. I have a number of patients who describe this, having some anxiety, and that seems to be worse, or it seemed worse than prior to starting the drug. There's generalized edema. I had one patient, for example, who had sort of this generalized swelling, which was refractory to diuretics and steroids and whatnot. Um, Fortunately, it didn't affect the airway, but it was sort of this almost anasarca type picture. So it's that was in one of the trials, and it was relatively, it turns out it's relatively rare, although some degree of edema is not. So I mean, you have to just remain flexible and make sure that that or be aware that not everything may be known about the full side effect profile of these drugs. I mean, pyrexia now and with the dabrafenib trametinib I've seen many times, and as I said, I mean, I had to admit a few patients to the hospital because of something that was almost resembled sepsis. Now, for the VEGF TKIs, for things like the hand-foot syndrome, I have a very low threshold to send these patients to see the dermatologists. Things like 40% urea cream seems is and moisturizing lotions seems to be crucial. I think there's still a lot of work to be done. There are a number of trials that are going on to examining treatments to support these patients, and we need more of that. In general, these are, I mean, when people hear that it's just oral drugs, it seems like it's like taking Tylenol, but it's not. I mean, these are very, very toxic toxic treatments. The difficult to treat side effects, things like fatigue. Yes, Ritalin sometimes helps a little bit. Antidepressant depressants sometimes help a little, but there's just not for many patients, there's just not a whole lot you can do about it other than dose reductions, or which is what I usually do. If I have a patient who has relatively limited disease burden, I usually start at a relatively low dose and then escalate my way up as necessary, as opposed to starting at a high dose and then reducing the dose gradually.
I appreciate Dr. Lorch for such a fantastic presentation and your generosity here with us and sharing your knowledge. Thank you, everybody, for attending, and looking forward to seeing all of you next week. Thank you.
All right, great. Well, thanks very much. Appreciate it. Bye-bye.